Yes, thank you, Matt. Thank you, Susan, for inviting me here today. Todd Weatherly and I have wanted to put a nice picture of the bar logo up for you so that you knew where you were coming. But breaking the crisis cycle, the care continuum, mental health solutions. Basically, we're a therapeutic consulting group. We have 5 consultants who work with us and an office manager who helps keep the ducks in a row. But we work a lot with attorneys, trust officers, guardians, care managers, and those kinds of folks because you specifically, if you're in the courts or you're dealing with anybody that's struggling with legal issues, a lot of times those individuals are folks they've gotten in trouble with the law because they suffer from a substance use condition, they suffer from a mental health condition, they've gone unstable, and they've ended up in front of the law because police are usually first responders to most of this stuff. And anytime I've got somebody with that kind of, I would say that, I don't know, 25% of my caseload involves somebody who has an entanglement with the law and is needing a lawyer of some kind. I bug Victor all the time to try and get people to help with guardianship, adult guardianship, and matters of that kind. Part of what I wanted to bring to you today is just kind of a frame of reference for why this gets so complicated as quickly as it does. And community resources are not always the ones that are responding in a way that we'd like them to. People have a hard time getting either in front of them or receiving the amount of care they need from them. And all of a sudden they find themselves in a lurch or off their meds or back into substance use. And this is not just individuals you see on the street. You're also talking about professionals. The lawyers are not necessarily, they are vulnerable to substance use, as are nurses and doctors and all kinds of professionals out there. So it's not just the kind of person you see walking on the street. A lot of people are in need and don't know where to turn to get it. So I set a bit of an agenda for us today. And part of what I'm going to do is go over the complexities of different conditions. Some of you may be familiar with this kind of stuff and some of you may not. Providers and levels of care. I just want to give you the framework for what we look at anytime somebody who's in need comes to us and says, hey, what do I do? Like, well, let's start here. And almost every client that we get, I'm given a description, the 5-minute description of what I'm about to tell you in a little more depth. Our consultants, of course, we've got 5 of us and we have different specialties. I happen to bring Mr. Brad Evans with me today. He is our young adult and adolescent specialist because dealing with adults is one thing, dealing with adolescents is entirely another. Their treatment paths and where you go for resources, they are different worlds and you've got to specialize. Otherwise, you're kind of doing a disservice to the clients that you serve. So this is me, and I know stuff, and I've been doing it for 30 years. That means I'm old. So, and I'm the president of our little group, Stucker, Smith, and Weatherly. So this is just a sample list of diagnoses that you can get out of the DSM. Bipolar disorder, schizophrenia, OCD, body dysmorphic disorder, substance use disorder, ASD, which is autism 1 and 2, personality disorders. There are a variety. There are 5 or 6 different personality disorders you can get. Co-occurring conditions, so people who suffer from mental health conditions also misuse meds, find substances to engage in symptom relief. There are all kinds of things that they're experiencing out there. How do you treat it? So this is one of 3 pages of different ways that you treat the conditions list that you just saw there. Now, I don't know, does anybody know what the DSM-5 is? Okay, we got 2 or 3 people, 4 people. So the DSM-5, the Diagnostic Statistical Manual for Mental and Emotional Conditions. So it's the coding mechanism that they use to bill insurance for a person who has a diagnosis of, say, OCD, obsessive compulsive disorder. There's a code for it. There's a condition for it and everything else. So the DSM-5 has been For every number, it's been revised twice. You have a DSM-1, 1R, 2, 2R, 3, 3R, 4, 4R, 5. We're going to have 5R soon. And the DSM is about that thick. So at any rate, I've really simplified a lot of what you're looking at here in order to, when you have a condition that you're diagnosed with, you want to look at conditions. These days, we're looking at them a lot more on a spectrum. You suffer from OCD, maybe it's mild. Maybe you recognize it. It's not something that interrupts your day. It's not something that causes you to miss work. You suffer from anxiety. You may suffer from low levels of depression. You may drink a little more than you think you should on the Super Bowl. So those kinds of things are kind of within this realm of sometimes people are referred to as the worried well, or just everyday life. You know, every once in a while you drink a little too much. When you start to get up in your 40s and 50s, people start to, if they haven't already had some kind of condition that they've struggled with, hormonal changes, age, weight, lifestyle, food intake, etc., all of those factors start to go in, and people start to have a little bit more serious symptoms, have a little bit more to manage their life. Then you've got the people who come to us as clients, and they have what we call symptoms meeting one of those conditions that are at a clinically significant level. So that means that their symptoms are bad enough that it causes them to miss work, or they can't keep a job, or they fail out of school, or they've been in jail, or they get arrested. There are all kinds of things that happen to their life, but their life is interrupted by the condition that they suffer from. If you get that person, let's say a person suffers from major depression and none of the medications seem to work, right? But they don't really drink, and they don't really use drugs. They don't misuse their prescriptions. That's not really the issue they're encountering. But then they end up in the hospital for what they thought was a heart condition. Except when they got to the hospital said, yeah, there's nothing wrong with your heart. It looks like you had a panic attack. You'd be surprised how often that happens. And it's probably somebody in this room has a story where they've got a loved one who has happened to them. Now you've crossed over a line. That line is psychiatric condition that required a visit to the hospital. The line up above that is a psychiatric condition that requires a visit to the psychiatric hospital and actual hospitalization. So a lot of the folks that are in legal trouble are probably in this category. Now, if you take this person who's suffering from depression and has these kinds of things, and suddenly they're starting to hit the lines up into a significant disorder, and you take that person, you decide, hey, well, we're going to put them in the hospital for a couple of days, and then we're just going to send them to an addictions treatment center because that's the only one we've got available, and that takes their insurance. What do you think the results are going to be? So what you've got to do is you've got to match the condition with the treatment. This is just one set of treatments. MAT, I'd like to point one out, medication-assisted treatments. Anybody know what that means? So in the addictions world, if you suffer from addiction to opiates, or even addiction to alcohol, or any of the variety of other substances, MAT is considered as a treatment modality where you're on maintenance Suboxone, which is a replacement opiate, or methadone. You might be on Vivitrol, which basically takes the urge to drink or to use away from you. This is called MAT, or medication-assisted therapy. You get a lot of treatment centers and a lot of recovery homes that are right here in our town that don't support that. They will take an individual who is on that kind of therapy. So you end up having to do a scramble to figure out where your person who's getting released from jail today on bond, and is homeless because the family has kicked him out and they won't let him come back. Where am I going to put him now? Can't put him in the sober home, or I've got to find the right one. Suddenly you're doing a scramble, which I'm betting as attorneys you don't have the time to do. Cognitive behavioral therapy, DBT. Anybody ever heard of DBT? Dialectical behavioral therapy. It's something that's used for people who suffer from anxiety and depression pretty commonly. neurofeedback, EMDR, rapid resolution. Yes, they still do electroconvulsive therapy. It's just not the big two pads on your head and shock you like one flew over the cuckoo's nest. It's pretty sophisticated these days, but it does work for somebody who suffers from severe depression. Family systems theory, equine assisted therapy. Anybody? Okay. You can probably take a guess. Equine assisted therapy. Grant could even speak to this. And I didn't introduce him properly, but equine assisted therapy is used a lot for adolescents and young adults, which is where Brant specializes. So you use horses, and you use horses because it's a nonverbal way of processing. Most adolescents and even a lot of adults don't like talking about what they're feeling or why they feel that way. So if you give them a method that is not verbal, it goes over a little easier. That's just one of the nonverbal methods. Art therapy is another. So the other piece to this that you end up putting into the equation is not only do you have the conditions list, the things that people suffer from at varying levels, you've got the right treatment. So if a person suffers from depression but doesn't have a learning disorder, I'm not going to send them to an autism spectrum program, right? You got to find the right program, the right place to send them, and a place that will take them. For you guys, maybe you have a client who's been violent. Maybe you have a client who's the beneficiary of a trust who's just cycled through over and over and over again, and you can't find anywhere that will take them. Except they're in the hospital again, and they're using again. Happens all the time. So part of what goes wrong is they might go to the hospital. And the hospital stay is going to last you 2 days, 3 days, sometimes as much as a week or 2 weeks, but not much more than that. So does anybody here know what the criterion? So hospitalization means that you're locked. You can't leave until they say you can. Does anybody know what the criterion is for hospitalization?
That you're endangered yourself or others.
Endangered yourself or others. So I've spent a fair amount of time, tried to drag Brant with me, well, at least once, going to the magistrate to file a petition for an IVC and standing in front and waiting. Everybody knows the lobby if you wait in for the magistrate at 9 o'clock at night, and wait for them to come and get me and make a pitch for why they should send the police to go get a person to involuntarily commit. It's quite the process. But once a person gets done with a hospitalization, what do you think the likelihood is that they're better when they get out? Pretty slim to none. If you, the person in this crowd, you weren't feeling well, felt like you were suffering from depression, and it'd been happening to you for a while, and one night it just got so bad you felt like you needed to go get help right then and there, and you went to the hospital for it, what do you think would happen? They tell you to follow up with another provider and turn you away. They might give you some meds out the door because you don't meet criteria. If you said, I feel like I'm killing myself, then you can walk in the door. They're going to give you some meds, give you what we call the velvet hammer, which is a lot of meds that make you feel like a space cadet and walk you out the door. So the thing about that happens to folks that you might be serving is that they're in a court case, or they got legal entanglements, they've been in treatment, or they've been in and out of the hospital, or some, bad sober home somewhere, or bad care home somewhere, and they're back in trouble again, is that they never get the actual level of care they need. So I've got 5 basic levels of care. You got the hospital. It's where you can get locked in. You've got private hospitals that can take you because you don't have to meet criteria. You just have to walk in willingly. Kind of down from that, you've got clinics and assessment clinics, stabilization clinics that kind of ride in the same territory. A lot of those will have a hospital they work with so they can lock a person up if they become dangerous. but most of the really fit folks are voluntary. After that, you've got residential treatment. Anybody know Cooper Reese? Cooper Reese is a residential treatment facility in downtown Asheville. 24-bed, primary mental health, residential treatment for people with severe conditions like schizophrenia, bipolar disorder, and others. Literally, it would take us 5 minutes to get there. Residential treatment lasts anywhere. So not only you got levels of care, right level of care, it's also got the length of stay. Hospital doesn't keep them long enough to really treat them or even evaluate whether the medications are right. So levels of care, they're in residential treatment. How long should residential treatment last? 60 to 90 days. It's 3 months. It's a lot of time for an adult, especially if they don't want to go. But if you think about it, a person doesn't really regulate on medications they've been given, no matter who you are or what condition you're suffering from. You want to look at 6 weeks before you really know whether or not it's working for you, whether you've regulated around the medication, whether it's causing side effects that are going to be bothersome for you, and what are the long-term impacts of the medication you're on. For anybody sitting in this room, by statistics, 30% of you are on a behavioral health medication or a medication that helps abate symptoms. That's just the statistics, SAMHSA statistics. 25 to 30% of you are on some kind of medication. The older you get, the higher that number goes up. When you're on a medication, everybody's heard these cases. Several rock stars are kind of in this category. They were taking antidepressant, and then they stopped taking their antidepressant, and they committed suicide. There's a huge court case. There's 2 or 3 of these out in the world. Part of that is because the medication got sued. The company that made the medication, the pharma, got sued for inappropriate, not getting people warnings and everything else. There were a lot of big lawsuits about this, but the main thing is the person just suddenly went off of their medication. Most of the medications that serve people with significant conditions, you can't just go right off of them. They're not quick acting. They take 6 weeks to get on. They take 3 weeks to get off. Work with a psychiatrist or a doc. Residential level of stay is there to not only say, okay, meds are working, maybe we need to tweak them, we take long enough. And then the other half is like, okay, so what do you want your life to look like now that you know that you have a severe mental health condition? How are you going to go back into the world? Some people can pull that off, but actually coming out of residential treatment is pretty vulnerable. So in come the other levels of care. PHP, partial hospitalization. A lot of times people have a housing component to it. They don't always. PHP is 5 days a week, 3 to 6 hours worth of programming, clinical programming a day, plus 2 hours of individual therapy a week. You get your weekends off. You get through that, that's about 6 weeks. You go down to IOP, intensive outpatient. People probably know what an IOP is. We have a lot of them around here. They serve a large, they're mostly addictions kind of service. We had one mental health, but it closed when Helene came. And then the other one is at the hospital. So IOP is 3 days a week instead of 5. And you do that for about 6 weeks. After that, you're looking at, you want to do some kind of supported living, whether you're going back to your home and somebody's giving you help, or you're going back into an environment where you can be sober or somebody can help you with medications. The clients that we serve, the ones that are pretty serious, and some of ours are very serious, they require this step, and without it, they end up cycling right back through the whole thing again. Now, one thing that is not on this sheet is cost. So you've got community mental health. If we're going to look at these in terms of quality, okay, get what you pay for. You got community mental health. It's the bottom of the bucket. Insurance dependent. So insurance pays for it. It's only going to pay for 28 days. It's not going to pay for any kind of housing if it's outside of a residential treatment environment. And you're going to probably fight with them over any of the reimbursements they give. You're going to do fairly okay with PHP and IOP. Insurance dependent means the person's got no financial resources, no real out-of-pocket money. Whatever it is over and above what insurance is going to pay, that person's going to struggle with paying the dollar. Your addiction place got in trouble some years ago because what they were doing is just taking insurance money and sending the client a bill but never collecting. So they were making agreements. It's like, look, we're just going to take insurance money from you. We're not going to bill you for the rest. That's technically fraud. And then you've got the private pay world. Cooper East would fit in that category. You're talking about for residential care, anywhere from $21,000 to $75,000 a month for care. Those are California rates. So you drop down, every time you drop down a level of care, that number drops. And that number may drop depending on whether or not you need housing support. If you need supported independent living, insurance doesn't pay for that. So you got a lot of people out there. The truth is in our country, we know how to do pretty good mental health care. We do. Not everybody can afford it. And not everybody has access to it. So if you can afford to pay for it, the chances are good you're going to run this entire cycle, get every last level of care that you need. And even for a person who suffers from severe and persistent schizophrenia, voices in the head, hallucinations, one of the most serious mental illnesses you've got, that person on the right medications with the right treatment can still walk out of a treatment cycle like this and have a real life. They can get a job, they can live independently, they can do all the things that everybody else does. Happens all the time. You just got to be able to afford it. Most of your insurance-driven scenarios, they'll pay for a little while, or you can get them to pay for a little while, but eventually they're going to stop paying. You got to figure out what to do. I've got families that are on our caseload right now. We cut them a discount because we know that they're navigating local resources and community mental health. It's like, look, do this, stay on top of this, call this person, go here, get this person to check your insurance. And you feel like you're playing whack-a-mole. But if you have somebody that helps you navigate it, knows the system, sometimes you can get good results. But you've got to stay on top of it. So this is a little bit about supported living. I won't read it to you. You've got it there in your sheets. Yes.
Can you differentiate between private insurance and Medicaid, Medicare coverage? Briefly about in those levels of care.
Medicaid pays for nothing. Medicaid will pay for the hospital.
Don't they pay for Suboxone outpatient?
They will pay for Suboxone. They will pay for your script, and they will pay for your therapist. They won't pay for any action. None of that is really care. That's somebody doing documentation, making sure that you're not misusing your medication. Because it's a controlled substance, it's a Schedule I substance. And if they don't track it, then they get in trouble with the law. So they're doing it for the law, not for the therapy. Medicaid has a couple of places. There are a couple of Medicaid places that are local to us, and every state and community has one or two of them. Most of them are addictions. There aren't any around here that are mental health other than the hospital. And when you get out of the hospital, we just went through that segment where it's levels of care, right? If you get out of the hospital for an episode, they're going to refer you to outpatient care, IOP. So no housing support and outpatient care. And how successful do you think people are at that? Doesn't work. It's not sufficiently taxed. I won't go through that with you. Supported living, if you've got an aging parent, somebody, there's a good portion of this group that probably has an aging parent. Supported living for an aging parent, take your meds, make sure you get fed, make sure you do the things during the day, have activities to do. It's not different for a 21-year-old. The activities just crank up and you want them to get a job. But you also need them to take their meds and stay sober and learn how to wash the dishes and learn how to wash their own clothes and make their bed. It's the same stuff. So this is the stuff that knocks on your door whenever you have a client that's gotten into legal trouble as a result of their condition. They've been hospitalized. You got them out of trouble. The court's cut them a deal. Maybe that got deferred to treatment, possibly. We have drug court here, as you know. And they go do that. But then what happens? On the other side of it, they go back to the family. They can't get to a job. They go back to living alone. There's no recovery support. They didn't have the right level of care or the right length of stay. They didn't have the right care in the first place. They're already a chronic relapser. They have repeated hospitalizations. They can't get out from underneath the legal entanglements, so they keep, even though they've gotten you to fix their legal problems, the police still know them that are looking out for them because they know what's going to happen. Repeated arrest, repeated crisis, or insufficient care, or medication management. It's probably the biggest one that we grapple with adults suffering from severe conditions is they don't do their meds right, or they just go off of them entirely. So when health deteriorates, families' lives and finances are jeopardized. Victor here can tell you what a person can do to a trust if they repeat cycles. People can burn through $300,000 worth of a trust and very quickly if they are not well. That's not even a big trust. And big ones are like, we're tired of it, right? So what is a therapeutic consultant? Just to prime brand myself here. We basically, not unlike attorneys, but in navigating mental health, we do a retainer, you get us involved, we stay involved to help you navigate each one of these steps and figure out where to go and what to do, and whether it's the right care and how long they should stay in, figure out whether or not you can use insurance and how much you got, and what kind of budget you got for paying for their now somewhere between 18 months and 2 years worth of a care plan. So we just walk you through all of that, because most people don't know where to turn. The cool thing we can do, however, again, I don't like reading to people, but we write letters to the courts. We summarize clinical data. If you're providing it for trust records, or you're providing it for court records, or there's a deferral that's going to be done, and you're trying to make a case for it, or a case for a person to receive a life sentence because they've been engaging in care or whatever, we can write that up and still make a 21-page psychiatric assessment into a 1-page document you can hand to the court. Most attorneys are very grateful for that. So, write support letters, compile data, work with you, attorneys, trusts, etc. And then we coordinate all the other care aspects. It's like, well, we got a doc over here, we got a therapist over here, we got somebody else, we're going to get them all on the same sheet of music. So working with the stuff is complicated, just like you wouldn't recommend someone defend themselves in court, represent themselves in court. Probably best they get an attorney. I would agree with that. If you got a serious condition that you're dealing with, or you've got a family member with a serious condition, it's probably good to get somebody who knows how to walk through it, because it's going to save you a lot of time, money, effort, grief, headache, etc. That's us. Questions?
I have a question, Todd.
Okay.
So I was listening to this, and I probably should have asked this beforehand so you'd be primed for this question, but my work is with business owners and employers, and so the way I run into this is if it's somebody confiding in me saying my kid is having a challenge, or my vice president's having a challenge, that's an easy one to transition. But do you have any guidance on when I am talking to my client, he's the problem, he's the one who needs treatment, like how do I have that conversation? Because that's a really challenging one for me.
I don't know if it was up there. There's a method called motivational interviewing, which is a therapeutic technique. It's pretty common. There's a therapist in town who's an expert in it. She throws workshops. We can do it here at some point in time if you want. But motivational interviewing. Everybody has. You're attorneys. You know what Socratic method is, right? Motivational interviewing is basically the Socratic method turned into a therapeutic technique. And it's a lot about asking a really good question that they can't escape. And so I know that your specific line is not defense attorney. So if you think about the way that you would interrogate a person on the stand that is not your client, that you're trying to get to slip up, the concept is basically the same. So you're telling me you want this, except I know that you've done this, 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 and this, and you're faced with all of these things. What is the likelihood that this thing that you want is going to happen if you don't resolve these other things? And you get the stupid face. And Socrates called it intellectual midwifery. We birth somebody's poorly aligned thoughts and constructs to be and bring them into light so that they can understand how poorly informed their decision making had been. So you can't control people. And I think that the bottom line is people got to want help. Maybe the people who are really sick, it's very difficult to force a person to get help, and even when they do, they resent it. But some people are hiding. They're hiding from their condition. They're hiding from their responsibility, and just like you can scratch at the surface, and the whole thing breaks. But the other thing is to be like, and I know where you can get help. It's one thing to leave to catch a person vulnerable, but being able to give them some kind of resource for help, someplace to go. We live in a community that's got a lot of it. Right? There are a lot of private therapists, a lot of good ones that are in this area. So it's pretty easy to go find a therapist. You've even got you've got apps, you know, BetterHelp and all these things. You've got ways in which you don't necessarily have to get in front of a person. You don't necessarily have to reveal yourself. You don't even necessarily have to be in the same town as the person who's serving you in order to get some level of help. But most people, everybody has catch-22, right? Book? Yeah, so knowing that it's hard to know that you need help when you need help. And most people go way over the line before they go find some. Unless you're a person who's just doing your own regular work, which I would encourage any person to do, you start getting bad off and you just duck your head down, you drink a little too much, and it gets a little bit worse. And then all of a sudden you start having some health issues, and all of a sudden your relationships at home are not very good, and you don't feel well, but you're just ducking your head and going to work and drinking some more. Not like that. If you find your life starting to get interrupted by the way that you feel and the way that you're managing the way that you feel, the chances are good you need help. It's a very simple equation. Is it interrupting your life in a significant way? If it is,
thank you for your presentation. We have a couple questions. One is, in what ways do you cooperate with Alcoholics Anonymous and Narcotics Anonymous? And the second is, what are your thoughts about intervention?
Well, you know, if you had Brand up here, there's a couple of different answers. So if you're dealing with an adolescent, it's very much a soft therapeutic approach. And AA and NA are a little too confrontive for adolescents. There are models out there that are kind of 12-step like, so that they can kind of approach the concept more gently. 12-step was written for adults. For adults, I don't like the word intervention. It gets, people think intervention and they think what you see on TV. That show, right? Intervention, which I have a therapeutic consultant colleague who's on that show twice. The whole white horse run in, get letters from the family, have everybody sit around in this confronted meeting and overwhelm somebody with the amount of support and, the fact that they need help and what you do to get help right now. It works sometimes. I would say that it is better to take your time if you can. Most people get in a hurry, and unless a person is really urgently bad off, the thing that I would say to that is that while you cannot control others' behavior, you can control your own. It's like, well, you keep doing these things and you keep not getting help that I think you need, or you've been hiding all these things from me. Now I'm going to have to set some limits with you, either in terms of our relationship or in terms of finances or in terms of these other things. But I would say that you should, let's say it's you, say you're the person who's got someone who's struggling with an addictions issue or drinking issue. I think 12 steps great, but it's not treatment. 12 step is maintenance. It's also free. So you've got some really strong 12 step groups, and you've got some ones that are not very well run. You know, if you go to the young adult 12 step group out on the end of Merriman Highway at the church on Thursday nights, they call it scratch and dent sale. And I'm not kidding. That's an expression they use in 12 step. It's a bunch of young adults that are picking up on one another, and everybody's got issues, because that's why they call it scratch and dent. That's terrible. I know it's terrible, but it's literally what they call it. So the point is the meeting doesn't serve the purpose that you want it to serve. You know, the 12 step is something that has got layers. You have people with 25 years in recovery that'll tell you something about, say, fourth step you will never hear out of a 20-something-year-old, because they got 20 years worth of time letting it live inside them. I could say a lot about this topic. I would say the first thing a person should do is go get their own help and say, hey, I've got a family member who is struggling with these things, and I want to figure out what to do. And if it's somebody that you love them first. I love you. This makes me hurt. Be honest, and then see if they're willing to go get help up there. Right?
A lot of the programs that we will work with also will have some sort of integrated step. So exposure to that, I've seen a lot of
With older adults, you run into the opposite. They've seen it, they've done it, they've been through it, they know everything they need to know. I'm not going to do that again because I've already done it before. Just they probably didn't invest in it as well as they needed to. Is the real issue, but they also don't want to sit and be bored. They don't want to sit through the same spiel again, and that's fair. So again, figuring it out depends on the age, condition, underlying mental health symptoms. Have they had an assessment? Have they been to a hospital recently? Have they been receiving help? What is the documentation they have for any of the clinical processes they've engaged in up to this point? You get one of us on the phone, we're going to drop a series of questions on it, and they're going to get long. I mean, our initial calls with clients are not less than an hour ever, really. So I don't know if that answered your question, but that was an attempt.
You just get information of teenagers and addressed it somewhat related to adults. Do you think?
I think it has to speak to you. It has to be your language, because your former bar administrator can tell you, and is very vocal about it. She's got one of the strongest AA groups that this town has, but not one of them has less than 25 years worth of recovery. And when they talk about 12-step, it's like a spirit to them. It lives inside of them, and they speak about it in a way that is inspiring. And then you go and find 21-year-olds, even 30-year-olds. You can find aspects of that, but it all depends on the depth in which they engage in it. There's a statistic about all these modalities for treatment. So for a therapist, maybe they use DBT or CBT, or maybe they use EMDR or some kind of therapeutic method for trauma or whatever it is. You find you get the same result. You get the same statistically significant result out of each method. The X factor is the alliance that person has with the person they're treating, what they call a therapeutic alliance. So I would say that it all depends on the alliance you have to that body of work, the alliance you have to 12-step. When it's done in programming, you've got people who really believe in it, have got many years worth of experience in it. They're delivering it in a therapeutic modality. They're experts at delivering it in a way that is clinically sophisticated. You get out in the world and you get mixed results. So I think that it's a wonderful and can be a very effective methodology. I also know it's not for everybody. And that's why you have 5 or 6 different alternative methods out there. 12-step is the most popular of them. It is the most widely used. And so we could go into a stats sheet. SAMHSA, SAMSHA. It's the substance use and mental health statistics, wide body of knowledge and writing and everything else. You can go dig into statistics for a very long time on that page, and it'll show you what the evidence-based practices are and evidence stuff about 12-step, etc. We can send you an email with that stuff if you're interested. Anything else?
We'd probably be remiss, since we're talking about mental health, if we didn't mention that the State Bar offers free mental health sessions through Bar Cares, and the NC-LAT program provides interventions for attorneys who are having challenges. I was thinking about this more in relationship to clients, but anytime we're talking about mental health, it's helpful to remember we have resources.
Cool. Kind of like an EAP a little bit.
Things you like.
Well, I would say golf, but I think that worsens me. It helps. I mean, physical exercise. I'm a mountain biker, and I like to hike, and I like the outdoors. That's why I live in the mountains. There's a couple of things that are funny. They did a study that's a person who's able to look out. If I look at this wall, my feedback is this wall. But if I look out in the mountains, I've got a view that spans across a wide area. And people who have the ability to look out and have a view that spans a wide area, looks out over things, tend to have better mental health than people who don't. So people who live in kind of tight quarters and cities and everything else. So I think, sitting on the deck's pretty good. If you live in a place where sitting on the deck has a nice view, which I'm thankful that I do. So those are the things that I do. And I also, take a dry January and keep the alcohol down and the sugar down and all those other things. There's all kinds of stuff that's out there about your mental health. If you are experiencing symptoms and things like that, I'm a big fan of neurofeedback. Huge fan of neurofeedback, and we have a very thriving neurofeedback center right here in town. Focus centers just down the road, over by the hospital. So if you're having anxiety or depression, neurofeedback can be incredible. And it's also non-invasive, and you don't have to talk about your problems. That's been great. Thank you so much.